Okay, good afternoon, everyone. Thank you so much for joining us today. My name's Charlotte. I lead on Health for Active Surrey, which is a not-for-profit organisation, and we're the strategic lead for physical activity for the county. Just some housekeeping rules. We'd love to see you, so do put your cameras on. But if you could keep yourself muted until we open up the floor to the audience questions, which is at the end. If you need subtitles, hopefully you'll see that they're on there, already on there. We are recording this, so if that's all right, any problems, please just say now. We'll put something in the chat box. Okay, brilliant. We're going to get started. So I'm delighted to be joined by a panel of expert physios. They're all working in different parts of Surrey on slightly different pathways, but what is common is that they're all seeing long COVID patients and they have a wealth of knowledge and experience between them. They are, as you would imagine, incredibly busy. In fact, one of them's had to pull out, which is Kaylee. But we're going to manage it between us. They're really busy, so I'm really grateful they've given up their time for us today. I'm going to let them introduce themselves, and I'm going to start with Alison.
Good afternoon, everyone. My name is Alison Kandaya. I am the clinical lead for long-term conditions out of First Community. We cover East Surrey. I am a physio by background, but I am managing a multidisciplinary team within long-term conditions, including long COVID over the past year. Thanks,
Alison. Sue?
Hello everyone, my name's Sue Longley. I'm the COVID clinical coordinator and senior respiratory physio and pulmonary rehab lead for East Surrey CCG. Prior to becoming the clinical coordinator, I was just doing pulmonary rehab and respiratory physio, and before that I worked in the acute sector in intensive care, so I've got experience of the acute and chronic side of things.
Great, thanks, Sue. As I say, Kaylee's not here, so Becky, please.
Hi, I'm Becky. I'm the inpatient superintendent physio at the Royal Surrey, and I'm a specialist respiratory physio by background.
Thanks. And Michelle.
Hi, I'm Michelle. I work with Becky at Royal Surrey as a transformation programme manager, but I'm also one of the physios for ME. So I've been linking in with my colleagues here at Royal Surrey around the whole long COVID pathway.
Great, thank you. All right, let's start with the first question. What are the statistics on long COVID in Surrey? And Alison, that's yours, I think.
It is certainly, yeah. I think just to say, firstly, it's difficult to have full details of the picture of long COVID at this point because it's a constantly evolving picture. And most of the published data relates to the acute infections of COVID, and we see less about the long COVID statistics. Having said that, we are able to extrapolate the prevalence of long COVID from the acute data because we know from the literature that it's affecting between 1 in 10 and 1 in 12 COVID-19 patients. So those patients will go on to develop long COVID. So in a prevalence study published by the Office for National Statistics in February this year, data suggests that in December, there were 301,000 patients in private households in England living with symptoms that had persisted and could be defined as long COVID. So that doesn't include our population in nursing homes either, and I'm sure there are patients missing from that. But there is obviously a clear problem with long COVID. So in relation to East Surrey, our long COVID service actually started back in April 2020 in response to patients needing acute rehab following a hospital admission. But as we saw that wave decrease, we saw a significant cohort of patients coming forward, still experiencing symptoms and seeking support from their GP months after their illness. So from the initial peak, our referrals peaked in May with 90 per month. And then settled in summer as we saw a better picture with about 20 long COVID referrals per month. But since January this year, we're seeing an increase in prevalence again, receiving between 60 and 70 referrals per month, the majority via the GP and the primary care networks from patients who've actually never been into hospital or actually didn't have a prolonged stay. As we speak today, we have 202 patients on our long COVID pathway in East Surrey, and I'm sure that is mirrored by our colleagues on the call. So as I said, overall figures suggest that approximately 10% of patients are going on to have these problems, and we have to assume that we're going to see a further wave. So based on the most recent 6 months, where we've got a likely expectation in East Surrey of 1,451 long COVID referrals to our service, that's what we're basing this on. So while we're seeing the welcome news of decreasing acute infections, I think we across the health service and the exercise sector need to be prepared for an increase of patients. So just final details from me. Most of our patients on the pathway are between the ages of 35 and 64, but we've had patients ranging from 18 to 90 years old. Our team feel we may be missing some groups of people, particularly we're going to be focusing on the Gypsy Romany traveller community and some younger patients in coming weeks and months. But overall, that's our picture in East Surrey, and I don't know if other panel members have anything to add to that.
Anybody else want to add?
I would just say that we're obviously in the second wave, but we on our pathway are still having people referred from the very beginning of the first wave. So we're getting people referred from the first wave and second wave, and we just anticipate that that's going to go up before it goes down.
Okay, great, thank you. Let me try and move the slide on. Okay, so what is long COVID, and is there a difference in those who've been in intensive care and those who have not? It's Becky, I think.
Yep, so this one is from me. So I'm actually going to kind of change the term long COVID based on the NICE guidelines, and we'll kind of explain why. So the NICE guidelines, so the National Institute for Clinical Excellence, have now produced a guideline which shows the definitions for the different stages of COVID infection. And this is a kind of constantly changing position that they've got. So in a very basic way, an acute COVID infection is demonstrated as signs and symptoms of COVID for up to 4 weeks. So that's that initial phase of COVID where you either have the typical symptoms or you're asymptomatic. The second definition is ongoing symptomatic COVID. So this describes anyone who is continuing to suffer with signs and symptoms post 4 weeks, but before the 12-week mark. So you've got that acute side, and then you've got your ongoing symptomatic COVID. Now, what we're talking about here when we're asking about and talking about long COVID is now being retermed as post-COVID syndrome, which are signs and symptoms that develop following an infection from COVID that continue for more than 12 weeks, and they cannot be explained by an alternative diagnosis. And that bit's really key for when we talk later on about when we're exercising these patients and when we're looking at referrals, because we do have to exclude other diagnoses first. And NICE are really key to point out that the symptoms do change over time. So COVID has been known to affect all the different body systems. So what you might have at week 6 and 7 might not be the same as you get in week 8 and 9. So the symptoms are forever changing, and they overlap each other, and they can be quite variable. Being post-COVID doesn't mean that your illness is over. It just means that your acute phase has ended and now you're moving on to a different phase. If you dissect the NICE guidelines a little bit more, they do talk about long COVID, and essentially that refers to both the ongoing symptomatic COVID and the post-COVID syndrome. So long COVID encompasses all of the long-term symptoms that people are experiencing. In terms of the question about is there a difference between those who have been in intensive care and those who have not, actually no, there isn't a standard kind of, if you've been in intensive care you're more likely to get it or you'll get certain symptoms compared to other people. And in actual fact, the NICE guidelines state that we as clinicians can't make any assumptions based on whether someone would be at risk of developing post-COVID syndrome based on symptoms, whether they've been hospitalised. There isn't enough evidence currently to support theories that particular symptoms or the severity of illness will determine your predisposition to getting post-COVID syndrome or long COVID. From a personal experience, looking at our intensive care and hospital admissions, I would say that I've seen more long COVID and post-COVID syndrome patients that have been managed at home compared to within a hospital setting.
Really interesting, thank you. So what are the common symptoms of long COVID? So this was going to be Kaylee answering this, but Sue has kindly said she would go through the slides that Kelly put together. So over to you, Sue.
Thank you. So the symptoms of asked, this is a summary of quite the sort of more common symptoms. So you have the fatigue, which we will go into in more detail later on. We've got breathlessness, so those are the very two common ones, and the brain fog, where a lot of you might have heard of the COVID brain fog, and that can be your short-term memory, it can be word finding problems, it could be communication problems, not being able to concentrate on a task, staying focused. Patients are saying that they can't watch a TV program all the way through, or they can't read anymore. And the brain fog is really affecting, well, it's affecting all patients, but with patients with a high level job, it's really affecting their ability to return back to work. So some patients are really struggling with that. Palpitations, again, is another one, and chest pains, and we'll cover this again in future slides. Pain, so joint and muscle pain, and this can mimic other long-term conditions, and also women going through the menopause. And the menopause, there's sort of discussions whether, you know, the menopause is made worse, or women are being diagnosed with long COVID when actually they might be starting the menopause. Sleep is disturbed, and that can go along with the fatigue as well. Memory and concentration difficulties, anxiety, and we haven't got on here depression, but that occurs quite often. And I'm finding patients that have suffered with anxiety and depression pre-COVID, it is very heightened post-COVID. And post-exertional malaise as well is a big factor. Anything else anyone else wants to add from the panel? No.
Wow, what a list, hey?
Yeah. I mean, there's another one I've been finding, that increased urinary frequency is another one, and it's, you know, what the cause is, we don't know, but we're thinking, you know, talking about it being a multi-system virus that attacks all the systems. There's the influence on the endocrine system, and then the hormones are affected, and that can cause a multitude of symptoms as well.
Great, thank you, Sue. So next question. What is the guidance and the current disputes about exercising when living with long COVID? So Michelle, it's over to you.
Thanks very much. And actually, it's as if we planned this, whereas we didn't have any sort of coordination, because I'm going to pick up a bit about the post-exertional malaise that Sue just mentioned before. So I think Becky's really nicely laid out the sort of different types, if you like, of what counts as and what comes into long COVID. And I think it's quite important also to remember that long COVID is a sort of patient-derived term, and that's very much come from people who are living with long COVID, and they like to call it long COVID rather than some of the perhaps more medical terminology that we might use. Regarding exercise, I think the first thing that's really important is around sort of risk stratification, and I'll come back to that in a minute. But when we are starting to exercise, it's if there's no symptoms for 7 days and it's starting at a very low intensity, so that's on the Borg scale, perceived exertion, that's sort of at a level 6 to 8. So it might be quite different to what some people have used before, and looking at from a 2-week perspective before starting to increase that. But from a risk stratification perspective, around if they've had cardiac involvement, because we know, as Sue said, it's a multi-system condition. Any myocarditis, there's 3 to 6 months with exercise restrictions, as there would be with any other myocarditis. Non-resolving or worsening respiratory symptoms are also worth investigation, but the post-exertional malaise, sometimes known as post-exertional symptom exacerbation, is, I think, the bit that's caused some of the debate, as in so what is that, first of all? Well, there's several, and this is where there's the real crossover in learning with the sort of ME world in which that I've worked in. It's an exacerbation of symptoms that leads to a reduction in functionality, or it's prolonged increase in symptoms after something that people used to be able to do quite easily before. So it's very different from the sort of classic muscle soreness that you might get after you exercise if you haven't got post-exertional malaise. And it's the fact that it just takes a lot longer to sort of shake it off, if you like, whereas previously you ought to be able to do it. We don't entirely know what the physiological mechanism behind that is, but we know that people with ME, and there's still a debate around whether, you know, the links between long COVID and ME, but it's very much a post-viral thing, and that we do have see an abnormal physiological response to activity. And that activity can be physical, it can be cognitive, it can be emotional, and it can be social. So it could be as simple as going and having a cup of coffee with your friend that brings on that increase in symptoms. So that's quite unusual for us, I think, as physios. We're quite good at picking up the physical exertion, but we have to start thinking about those other bits as well. So really, it's really important for us when we're looking at any sort of exercise activity program that we know whether or not somebody experiences that post-exertional malaise. So how do we identify that? And there are various different symptoms questionnaires that you can use out there. The DePaul symptom PEM questionnaire is one. But I think for me, it's around actually having that conversation. In physio terms, we'd call it our subjective assessment, but it's really having that conversation with people around what happens if they do try an exercise, what happens if they tried to go out for a walk, what happens if they tried to get back to the previous activity, what happens, as Sue mentioned, if they try and concentrate in a day at work. And then seeing if that creates a worsening of their fatigue or their other symptoms after they've done that, and also how long does it take them to recover. So if we've got somebody who has got that post-exertional malaise, we need to take a very different approach to somebody, for example, who might be deconditioned after a prolonged stay in ITU. And there's a lot of transferable learning from the ME, chronic fatigue syndrome, that we can use, which is around using heart rate monitoring and using pacing to stay below the anaerobic threshold. Interestingly, previously we might have used 55% of maximum heart rate, but the latest evidence coming out from the States is keeping it at 15 beats per minute above the resting heart rate. And I think for me, that's, if you think about that and how little you need to raise your pulse rate by 15 beats per minute, it really shows how much we need to scale back some of our expectations around prescribing exercise, prescribing activity. I could talk for hours about that's a whole side of it, so I'm not going to, but just to say, I'll drop into the chat that we've got quite a lot of information and some podcasts on our website where you can find out about all the exercise physiology, and Long COVID Physio have also got some, so I'll put the links in for that, and if you need any more, go off and have a look. So I'll stop there, otherwise, as I said, I'll be talking for an hour. So over to you, Charlotte.
Okay, thanks, Michelle. So next question, I think this is Sue. What support is available for those with long COVID?
So the support is growing, I would say, but they're still not vast. There is, some of you probably heard of the Your Recovery website for COVID, which is a national website that's accessible to all, so patients, carers, and just anyone that's got a general interest. But there are 2 levels to that website. So there's a second level where the patient needs to have a one-to-one assessment with a healthcare professional for them to gain access to the programme. Now, nationally, different services have or haven't signed up to the Your COVID Recovery website for different reasons. Within East Surrey, First Community have, but we are actually winding it down because it's quite labour intensive. And it has a very big exercise base to it. And because of the problems with patients with fatigue, it's not always the best programme to have, because it was developed up by Leicester, and they're very pulmonary rehab based. And last year, it was very push pulmonary rehab, get the exercise, graded exercise. But what we're learning now is that graded exercise is not always the best for these patients, and that obviously goes against the grain of physios and exercise instructors, and we have to change our thinking really. So we are going to still have it accessible to patients, but it takes a lot to actually manage it, and I'm the only one doing all the clinical coordinating as well, so it's not feasible. And even Leeds, who have a vast team for long COVID, they're not even using it, and their team is substantially bigger than ours. So we're doing what we can, but I would say that if a patient is wanting access and they can't have it, I would say it's not the end of the world, because it might not be appropriate. But also there's a lot of information on there. And if you've got someone that's struggling with fatigue and is struggling to concentrate and to read, again, it won't be the best platform for them, okay? And obviously you have the technical issues as well, and having the right means to actually access the platform. So there's that's that online platform. We have access to talking therapies, which is specific for COVID, which we can refer into, and also long COVID support group within the East Surrey CCG network. We also refer to wellbeing advisors, which can help with general health, and also they can help with just general support if someone's lonely, feeling isolated, but they're not counsellors, so we have to be very aware of that. But if someone's a little bit anxious and needs just that little bit of support, we can refer to them. There are Facebook pages, groups, but I would say use these with care. I find that they can be quite a negative. Initially, you think this is a great support network, but then when you get quite a lot of people on that group, there can be quite a lot of negativity. And if patients are suffering from anxiety or depression, it feeds into that. So it would not actually be a platform that I would recommend necessarily. And also you get intensive care support groups for those ones that have been critically ill. There are specific support groups that the hospital should be able to advise the patients on for that. Is there anything else anyone wants to add from the panel?
Are there any other support groups? I mean, you mentioned the one in East Surrey. Are there any others across the rest of Surrey? Does anybody know? No? Okay. So the next question, physical activity is not the only part of support, and you've mentioned a lot of it already. So what are the elements, other elements that are needed or offered to patients?
So if I explain our triage, what we do, and then that will explain the sort of where we signpost people. So patients, when they're referred to our pathway, they're sent a COVID rehab booklet straight away, which has information on managing the common symptoms within COVID. Then they're obviously on a waiting list, and unfortunately the waiting lists are growing because of resources. But then once they get triaged by myself, we ask them, we use certain questionnaires which are recommended by NICE to screen for the multitude of symptoms which we've already discussed. So then I, as a coordinator, can work out where their needs are to be able to signpost them. So for those that have fatigue or cognitive problems or memory problems, we refer on to the occupational therapy team. And there's the fatigue element, where some patients will just have fatigue, and there will be some that will just have cognitive, but quite a lot of the time it comes hand in hand, okay? We refer to dietitians as well. Not a lot of referrals, but there are the ones that still suffer with problems with taste and smell. And that's really affecting their ability to eat, where they're not actually taking in what they should do. And others have put on a lot of weight, so they want to try and manage their weight and eat more healthily. Speech and language therapists we refer to. We have some patients that say that their voice has been affected and it tires or it gets hoarse. A lot of patients, when I ask them that, they say, you know, yes, it's okay, but it doesn't really impact me, and they don't want referral on. But then some do. There's some that do have swallowing problems, and they complain of food getting stuck in their throat. They complain of ongoing throat issues. And you also get the ones that have come out of intensive care that might have had a tracheostomy, and they have ongoing problems as well with swallow. So we refer those patients on. General rehab. So there's patients that might not be suitable for pulmonary rehab, but just need some basic rehab and some maintenance exercises. So sometimes the ones that are presenting more with a chronic fatigue type picture might need some just general maintenance exercises. So we refer to general rehab physio, which we have in our team. And musculoskeletal physio we refer to as well. We're lucky that we've got input from some clinical specialists, spinal and shoulder, so we refer on to those. You have the patients that come out of intensive care that might have problems, particularly with their shoulders because of the proning. And some of those have had to go on and have further scans because of potential damage that's happened to their shoulders. And we've had people with spinal issues as well. I've already mentioned the talking therapies, the COVID support and wellbeing advisors. We refer back to the GP as required if things are flagged up, or if certain tests haven't been done when they should have been done from when they were first initially referred to us. And we also have the ability to refer on to our consultant. And we have to be careful because we don't want to over medicalise long COVID, and sometimes the patients will recover spontaneously, and it's sort of trying to allow the patients to accept that it is a long road to recovery. It's not just a quick recovery after a cough or a cold. It can take months, and we need to allow them to have that spontaneous recovery before we start ordering unnecessary tests. Obviously, if there are some red flags, which I will talk about shortly, that come up, then those do need to be investigated, because we do need to rule out any red flags. And you have the thing that COVID will cause other problems, and there is increased incidence of cardiac problems and respiratory problems, as we know, and so those do need further investigation and may need specialist input and scans. So our consultant at the moment, I know he refers on to cardiology, endocrinology, neurology and immunology at the moment. So yeah, anything else anyone wants to add?
Just to echo what you're saying, Sue, I mean, we've got the statistics here a little bit on the referrals you're making, and 15% of our patients are being referred back to a consultant at the moment. So it is only a small proportion, and I think we are following what Sue's saying there about not trying to hyper-medicalise things. We have really good links, and we're very lucky to have that, but it is only 15% at the moment, which is great. And I think just to echo what you were saying earlier about it being around activity prescription rather than just exercise prescription, I think the surprise we've had, particularly in the second wave, has been the amount of patients needing that OT input. So 55% of our patients are now actually needing occupational therapy. Many still need physio, 40% still having pulmonary rehab, but we are seeing a substantial amount, as Sue mentioned there, with fatigue and cognitive issues. And I think that's becoming the bigger challenge for us, and perhaps we were staffed more towards a physio bias, so that is becoming a bit of a challenge. But just to reinforce what Sue's saying there, really.
And I would say, oh, sorry.
No, I was just going to jump in and say there's the whole vocational side, isn't there, of OT and occupational health as well, around returning to work and what that looks like, which I think is really important. I don't know if anybody's got any data on that, but I think we're seeing that quite a lot.
We definitely are seeing that with our occupational therapy team getting involved with vocational rehab, and I think that's because we are seeing such a young population. Actually, we've got so many working age people here that is actually becoming more of a pressure for the team. Again, it's about pacing and fatigue more so than anything from what I'm seeing in my interactions with the team, but it is a huge problem.
And the thing is, I'd like to say that the other thing is anxiety, and it's obviously supporting the patients with anxiety, but we have to be careful that we don't promise something we can't keep to, because we don't know. Some patients are recovering very well from long COVID and getting back to their normal lives, but we are seeing patients from back from March, February, and they're still suffering, and we don't know whether they're going to make a full recovery. And so we have to be careful that we're not promising that they will. The COVID rehab pathway is more about giving the patients the tools to help manage their condition. And part of it is also we have a professional responsibility to actually say, you know, or sow that seed that they may not get back to their pre-level of function, because from a psychological standpoint, we don't want to be going down this rehab pathway and setting them up with that, I'm going to get better, because psychologically that's going to really affect them and affect their depression, anxiety levels later on down the line. And so we have to be really careful from that perspective.
Gosh, it must be devastating to hear that for these patients. Really tricky. Great. If nobody's got anything else to add, we'll move on to the next question. So this is one that Kaylee was going to answer. So there's 3 parts to this question. So if I just put up all the questions and I can go to her slides. So should exercise specialists take on clients with long COVID who self-refer? What should GPs screen for before giving patients the okay to work with exercise specialists? And what should exercise specialists screen for? So, oh, have I made a mistake? Was that somebody else's question?
I think that the top part was my question, Charlotte. But that's fine. I can go to the other 2 parts as well. So this is a really interesting question. And actually, when we all met to plan this session, my initial answer to this was an absolute no. But I've actually half changed my mind. So I'll explain kind of what the reasons behind that are. So from a physiotherapy point of view, and when we're taking referrals into our long COVID clinics, we do ask for GPs to have screened all of our patients before referral. And the reason for this is based on the NICE guidelines, all other diagnoses need to be ruled out first. And we're not the ones that are the best at doing that. That is the GP's responsibility and their area of expertise to look at the patient as a whole and decide whether that fits in with a COVID picture or actually does that fit in with something else. And as Michelle touched on earlier, we need to look at those patients that have had cardiac infection, those patients that are having worsening shortness of breath, ongoing respiratory symptoms. So from my personal and professional perspective, I would always err on the side of caution and perhaps ask patients and clients who are coming into an exercise setting, if they are demonstrating signs of long COVID, that actually they get the clearance from their GP, as we would ask any other client coming into an exercise setting. Having said that, freedom of choice, free will, and ability to decide for yourself still counts. So if a client is coming into a gym setting and they're very specific about what it is that they want, and they have looked at the declaration questions that most areas would have in terms of, have you got ongoing symptoms, have you got breathing problems, have you got cardiac problems, as long as we're making them aware that they should ideally have GP clearance and they're telling you that they don't want to, that they're absolutely fine, that they don't have all of those symptoms. Again, the same as Michelle was saying, if you ask the questions of what happens when you exercise, what happens when you've been to work for the day, if nothing is screaming at you that there are issues, then it would be okay to proceed very cautiously in the first few sessions and then decide from there. I think it's exercise in a gym-based setting or a personal training-based setting is always with a risk assessment. So is that patient still exhibiting signs that need to be investigated or not? I think also it's about that ongoing monitoring. So what happens in the first session may be different in the next few sessions. So always follow up your clients, whether that is giving them a call the next day or asking them to touch base with you after their session, just to see whether it was appropriate or not. So I think that it's a hard question to answer. I would always err on the side of caution if I felt that the symptoms were suggestive of that. But if they were a patient who is just showing you that post-viral deconditioning, then it would be okay to proceed with all of your ordinary screening questions. I think touching on part B, what should GPs screen for? That's a very open-ended question. GPs will have their own screening methods, and they will be basing their assessment on what the patient is saying to them. So if the patient is complaining of cardiac symptoms, they will refer to the cardiologist. They will refer to respiratory doctors. I've just seen at the bottom, someone's asking a question, do GPs have the skills and time to screen people? The thing is with that is that the role of a general practitioner is to have the assessment skills to screen people for illnesses. Now, we're all in the same boat with COVID, that we're not sure how it's going to present, but we work on a symptom-based approach and what the patient is telling you rather than a what fits into what bucket. So the GPs are the best people to refer on to all of the specialists. The majority of areas can only have referrals in via the GP. So if a patient needs a cardiologist, the GP is the one to refer into that service. So the GPs are the one with the overall responsibility for patients in the community. And in terms of time, again, everyone doesn't have time in all of their areas. We're all making time, and it again it's the division of how we prioritize our patients and what we do. So these patients are fitting in terms of GP time. We're not increasing the number of people that are on their books. We're perhaps just increasing the workload at specific times. So I think there will be some more work being done as to how much that impacts on the GPs and the outside services. And then in terms of question C, so looking at what should exercise specialists screen for, again, your usual screening practice should be adequate at the moment. So in any patient or client when they're going to a gym setting, when they're starting personal training, should be being screened. Do you have any history of cardiac issues? Do you have any respiratory issues? Are you on any medication? And then perhaps using some of the measures from asking the patient, if you walk 10 meters, 20 meters, what happens? If you do your normal exercise, what happens? If you go to work, what happens after that? I think a lot of this was covered from Michelle's aspect in terms of looking out for that post-exertional malaise. But a general screening should be absolutely fine. And I know a lot of gyms in the area that are running post-COVID programs are using their generic medical screening as a good basis to start on.
Becky, can I just jump in on that? Because there was one thing that you said that I think was really, really important about checking in a day or a couple of days later. And that's probably the thing I didn't mention about PEM, post-exertional malaise, is it's often delayed. So it's 24 hours, 48 hours, 72 hours after the activity. So that is, I would say, that's absolutely, ask them about what happens when they do the exercise, but also whether that comes on several days later, and then do that ongoing screening as you're going to see whether or not they are getting, whether they're getting that PEM. And sometimes it might be that they can exercise to a certain level, but then when you start to hit their anaerobic threshold and push them harder, that's when they start to develop it. So I would say that's an ongoing screening or checking constantly around post-exertional malaise with this cohort.
Brilliant. That's a good, yeah, carry on.
just touching on that point, I think this particular illness shows a really good need to keep a log of what exercise we're doing and how the patients are managing. So something that we would do in pulmonary rehab, which we do with our long COVID patients, is really clearly documenting what the patient has been able to do so that we can keep an idea of what's happening and how things work with each session.
Brilliant, thank you. And for you to carry on, so what are the red flags in screening monitoring? Some of them have already been mentioned.
Yeah, so chest pain and palpitations are one of the first ones. You get, some of the COVID patients get what we call COVID chest pain, but we need to work out whether that is due to their COVID infection or do they have an underlying cardiac issue. So if patients are being referred to our pathway, if they've got chest pain, I'm asking the GP, okay, has other causes been ruled out for this cause of chest pain? Have they had an ECG done? Okay. Are they getting breathlessness with chest pain? Because there's an increased instance of PE, pulmonary embolus, in the community. And we don't know that the patients have got them until they're pushed a little bit further. And one of the things that's coming up is they're coming in for walk tests or sit-stand tests. And if you're noticing that they have low sats or fluctuating saturations, that's then an indicator that they really need to have specialist assessment, really. So Wayne put a question up about SATS monitors. We are not giving patients SATS monitors routinely. I know in the acute phase, when they were monitoring patients at home, GPs were giving SATS monitors out, but by the time they come to us, we're checking them when they first come in, and we check them for the walk test and their sit to stand. And if there's no changes in their oxygen levels, then we don't worry about that. We just get them on. Obviously, if there are changes in their oxygen levels, we need to investigate that further. So if you're having anyone that is having low saturations, I would be very careful with actually continuing with exercise, because really that could indicate that there's a bigger problem going on, which is not being picked up. So we need to be aware of the PE, because the clotting of post-COVID patients is affected, and that's what's leading to the incidence of PE. And I'm finding a lot of patients are going back to A&E post admission from hospital, but also the ones that weren't managed in the hospital are attending A&E, and that might be from 1 attendance to 4 attendances in a month, because they've got this ongoing chest pain. So you do have to be very careful with that. We're seeing instances of exercise-induced bradycardia as well when we do the walk test. And again, we refer back to the GP, or depending on where they're at, I will refer on to the consultants, because that will need further cardiac investigation. We are finding that COVID is causing cardiac problems, but also it's highlighting pre-existing conditions, but actually has almost progressed them, and then now showing more clinical signs. So it was pre-existent and it's now coming to light. COVID's brought it to light. So with the desaturations, again, really you need to be referring back to the GP, because it would not be safe as an exercise instructor to be continuing with that. So those are the main red flags that I would be saying, but also really with the fatigue. If you've got a patient that is struggling with the fatigue, I would be questioning them actually coming to you having an exercise session, because what we're learning now, less is more. I've got a lady who is a young mum, say young, I still count myself as young, she's similar age to me, she's in her 40s, 4 young children, used to run 5K regularly each week. She is now presenting with severe chronic fatigue. She's gone out and bought a mobility scooter. She can't stand up to serve her dinner, you know, to her family. She has to sit down. She's got a multitude of problems. And with these patients that are suffering with the fatigue, less is more. And what I'm telling my patients is you need to respect that fatigue. So when I'm triaging, one of the red flags really is fatigue, because if you push them and I refer them to pulmonary rehab, that could set them up. And the message we're getting and what we're extrapolating, and Michelle, I can see you nodding your head well here, yeah, is the with the chronic, what we're extrapolating from the chronic ME and chronic fatigue patients is that if you push through fatigue, you're going to prolong the recovery. And actually at this stage, less is more. And I will say, you know, some patients are not leaving the house, and I will say, okay, well, can you just go out and walk down your drive to your the road, and then go out of your house for 2 minutes, and that will be exactly what I mean, 2 minutes. And I would say do that every day. When you've done that for a week, okay, that's fine. Increase it by 1 minute. That's it. But it's the problem we have, all of us have, is where do we put these patients? And this is where it goes back to what Michelle was saying with when we question them, how is their fatigue affecting them? Okay, do they feel fatigue straight away? Is it just after they've done the activity? Is it the delayed onset? are they actually working, and are they going out for a bit of a walk but they complain that they're tired? Those ones might be more suited to the pulmonary rehab and the graded exercise. But even if they do have fatigue, they need to respect that. And we have some patients that say they sleep during the day, or they don't want to sleep, but they feel like they sleep. The message we're giving is it's okay to sleep, but give it a routine. So if you feel that you need to sleep during the day, try and make it at the same time each day. Like our body likes to sleep at night. If it's requiring sleep during the day, we need to have a routine to that sleep. But it's giving the patients that permission, or they feel reassured that if we say yes, it's okay, because that's how we need to manage your fatigue. And everyone is really different. I don't know, Michelle, do you have anything else to add on that?
So I suppose just looking at the slide, no, I would absolutely 100% endorse. You saw me frantically nodding, and I think the bit around, I touched on it lightly, and we don't have time for me to go off into a lot of detail, but the work around heart rate monitoring is definitely something that we've seen some really good results with people who use that as a tool around helping manage their activity levels. It's not as straightforward as it seems, because we've talked a bit about cardiac involvement, and there's quite a few people who've got POTS, postural orthostatic tachycardia syndrome, or orthostatic, so their pulse rate will suddenly scoot up when they stand up and do anything. And so it's around knowing how to manage that. But I do think there's something around learning about how to teach people to understand their heart rate monitoring and around pacing. And I put, as I said, I put the links into some websites where you can find some more information about that. But I think it's also recognizing that for some people, as Sue brilliantly said, this is a sort of an ongoing thing, and it's about learning to self-manage their condition, just as we might work with somebody with diabetes or somebody post heart attack or with angina, around how they have to learn to sort of self-manage their condition as they go on. But 100% agree that fatigue is telling us something, and they need to, there's quite a lot of stuff out there as well around energy envelope and budgeting around energy, and the OTs, this is their bread and butter stuff, isn't it? But around, if you sort of think that you've got a set level of energy that you can use during the day, so one day you may have to go into work or do something cognitively quite loading, so therefore you shouldn't try and perhaps do as much physical activity. So it is, I think it's quite complicated, and I think it's about being aware of all of this, and also about signposting onto other people, recognizing that we as physios or exercise professionals, we may not have all the skills and knowledge to deal with this, and it's actually a sort of multidisciplinary team approach to it, I think, would be one of the core messages.
Okay, great.
I would say also with the your high level exercise patients, they can be your tricky ones as well. So I've had some that, they do Ironmans, and, they're now struggling to do 3 kilometers. And it's psychologically, it's very hard for those patients. And that's where we have to say less is more. And they may not get back to that pre-level of function, but also we have to say to them, you need to rein it in, because they are so high level, they really are used to pushing themselves, and so they don't actually feel like they're exercising if they're only going out for a 3k run or walk, but then actually they're going to prolong their recovery and their symptoms if they don't rein it in, and that's really hard with those patients.
One of the things that we found, and it picks up on what you said about fatigue, is around is the idea of active rest, is that actually it's helping you to recover, and so it's giving people a purpose to their rest, if that makes sense. And I think for some of the, as you talked about, those sort of high elite athletes, actually that suddenly gives them a structure to that, and it says, okay, yes, rest is doing something to help me get back, rather than just saying have a rest. And I think that's equally important, is around recognizing rest, and by rest, that's no TV, not reading, it's total rest, recognizing that cognitive, emotional input as well. So it's tough.
Wow. I agree. I think that just that's the message from our OTs, is it's giving people permission to feel the way they feel. I think that some patients are perhaps struggling with, other people's perception that they're being lazy or that they're not trying, and they're facing challenges within their own home life or community. And actually, one of the things the OTs in our team are doing is giving them permission to have fatigue, to have this as a valid symptom, and to allow those kind of structures to be put into their day to manage it, because I think some people feel like that it might be all in their head, as it were, and I think I've heard that quite a few times from our OTs. So it is permission to be unwell in a longer term fashion for somebody who's never been unwell before.
Yeah, definitely. I'm really sorry I'm rushing through this because I'm conscious of time. So how should exercise specialists best measure improvement? We have talked about this, but Kaylee put together a slide. So I think that's a bit obvious. We've talked a lot about those things that you should be measuring anyway. So if you've got questions, please do put it in the chat. So it seems that working with long COVID patients is a continuous learning curve. I mean, I think that's so evident. Where can professionals share and get support? And this is what we got from Kaylee. Anybody else got anything to add? Please do. So the NHS websites, Your COVID Recovery, Long COVID Physio, National Institute for Health Research. I'm sure it's easy to find those websites. And NICE, of course. Twitter, I think that's a massive platform for sharing. Anybody got anything else to add?
I think that's quite comprehensive, to be honest, in terms of the main resources, the mainstream ones, as it were.
Right.
Yeah, and I think Twitter's fabulous. If people aren't on Twitter, you can go on and you can ask a question and you'll get, some great insight from people. It's certainly, I think, been a sort of game changer in how the knowledge has spread so quickly.
Yeah, absolutely. So long as you're checking your sources and that
Oh,
they're
100%,
then I think
yeah.
I think absolutely I agree. It's been a really useful thing for me, certainly trying to keep track, especially outside my normal profession. I found that really useful. This is me, wasn't it? Suggested reading. I've kept it quite sort of entry level, simple stuff at the moment. I think the most important thing is to keep in touch with the COVID guidance as it comes out. The publication I've put up was mainly about long COVID or post-COVID syndrome, but there have been further NICE publications since then, predominantly around medications, etc. But it's just about keeping abreast with emerging evidence from NICE, because I think that is, as we've said all the way through this, we're learning as we go. Our whole programme has evolved completely from last year to where we are now. So it is about keeping up to date and not assuming that what you read is still accurate. I think that's the big message. This is already mentioned as well, the Your COVID Recovery public facing website you can access without any kind of registration, and it's quite a good useful tool. And then there's just a further reference there about post-acute management in primary care, which I found interesting. Obviously, Michelle's already shared some links about post-exercise fatigue, etc. And I think those are going to be very useful for you. But I think it is just about recognising that it is a need to get onto those platforms, get onto Twitter, get onto the NICE guidance, and get some alerts sent to you about what's coming out.
I think Laura's popped those links into the chat. People want to obviously just link straight to it. So hopefully that's there. I can't see the chat. So in summary, I think it's clear long COVID can be different from everyone. There's no one size fits all. A bit of a minefield. We're always learning on what's coming next. It could be one step forward, 2 steps back. I think the panelists have highlighted what we need to look out for and consider. And I really hope it's been helpful. I know we're a little bit out of time, but if the panelists are okay to stay on, has anybody got any questions? And Laura, you might have to tell me what's in the chat.
There's one on what do this imaging and CT scans. So what they're looking for referral into our pathway, and I think most pathways across the country, is that patients should have an X-ray for referral in. And what they're looking for is any chest X-ray changes as a result of their infection. So some that have had quite a bad infection still have, changes on the X-ray. But what they're looking for is there going to be development of fibrosis, because other COVID infections in the past from research has shown that a small proportion go on to develop pulmonary fibrosis. So obviously, if they do, it's up being able to identify those patients and those patients having the appropriate treatment if they develop on. But it is a small proportion of those patients that do.
I think it's also key to note that actually you may still have symptoms but not have any chest x-ray changes, or your changes may have resolved. So just because an x-ray of your chest doesn't show anything isn't indicative of not having any of the other symptoms, but it is a useful tool in the longevity of how COVID progresses with the patients.
Yeah, and to add to that, it's remembering that, going on from they've still got the symptoms, a lot of the long COVID patients are developing abnormal breathing patterns, and that is exacerbating their shortness of breath, and can actually mimic a lot of other symptoms, which I won't go into, but it can cause cardiac symptoms, but there's a long list. And as exercise instructors, I would really encourage you, if you are treating any patients with long COVID, is just really be aware of how they're breathing, because a lot of the COVID patients are losing that natural ability to control their breath when they exercise, even on minimal activity. So that is one thing to be aware of. I've got another question here. Would you recommend long COVID specific exercise sessions or manage within a current programme? Does any of the panel have any views on that?
I think it's dependent on the patient, and I think everybody's talked a lot about it's about the individual patient. I would say from a professional perspective that an initial assessment and initial interaction with someone should be on a one-to-one basis, to really listen to them, what it is that they want to achieve, how they learn. Everybody has different ways of getting back to normal, learning different skills. You'll find some patients really relish in a group environment where they can share their experiences with other people and they're motivated by others, but you will find that some patients really don't enjoy that. They won't exercise, they don't want to engage, and they're much better one-to-one. So it's really about that individual patient. What we found from a pulmonary rehab versus COVID rehab structure is that we don't feel that our patients fit into that pulmonary rehab style, in terms of, yes, a class session might work for them, but their experiences are very different. They can't do a lot of learning from each other for a lot of those things. So we've chosen not to integrate our pulmonary rehab class and our long COVID classes, but certainly the type of exercise can be very similar. So it's all really dependent on your individual patient and what they would prefer to learn.
Great.
I would agree with that, Becky. And yeah, we're the same. We're not, when we do go back, or when we were going to start classes and then we had to stop last year, we weren't going to mix the two. And yes, it is very individual. And I think now we've got the impacts of fatigue as well. And also I would say patient anxiety. There are some patients that don't even, they don't even want to come for a one-to-one. And we've got to manage this anxiety of coming out of lockdown and embracing life again, which is another aspect that we have to manage.
Okay. I don't know if anybody's seen it in the chat, but if there's a link to one question for us to find out what you thought of this, if you could click on that, that'd be brilliant. I still can't see the chat, so sorry. Are there any other questions?
Sorry, you're not missing anything, Charlotte. Everything's been covered.
Brilliant. All right, so that just leaves me to say thank you so much, panelists, because I know how busy you are. It's been amazing. It's wow, there's so much information out there. And I hope everyone's found it useful.